Great. Thank you, Ashley. Thanks everyone for joining us again tonight. Phil, what number are we?
42.
42. You got it right. Way to
Good job,
go.
Phil.
Way to go.
I
Number
just guessed.
42. Yeah, was a good guess. Great guess. Number 42 tonight, everybody. We have a great panel tonight. We have three people speaking with us. I'm Rob Manske from Wichita State University Department of Physical Therapy in Ascension Via Christi. Thanks everybody for joining. Thanks students. I think we have some of our students on, so shout out to them. Phil will give his shout outs in just a few minutes. I'll let our host tell you a little bit about them before we introduce our guests. So Barbara, take it over.
Oh, me?
Go ahead, just
So I'm
introduce
Barb
yourself.
Hoogenboom, recently retired
That's
academician
right.
from Grand Valley State
Congratulations. Yeah.
University, but still very busy in the world, but yes. And I hail from Grand Rapids, Michigan. I'm the editor-in-chief of IJSPT. So I've had the pleasure of working with all of my IJSPT colleagues as well as these authors. So really excited for you guys to be here. Thank you.
All right, Phil.
Bill Page, professor at Franciscan University in Baton Rouge. Shout out to our students and some of our guys from Tulane are here that we work with. Actually doing some good baseball research with Tulane. So I'm very interested to hear what you guys have to say. I really enjoyed the paper. Look forward to it.
Awesome. All right, we'll start with our. I guess if George is the general, are the other two? Are these guys? What are these guys, George? Are these guys privates? What are they? What would they be?
Do they make like lieutenant or?
Yeah. What rank are these guys, George? We'll introduce you in a minute, but I just need to know what rank these guys are.
Let's make them all colonels.
All
Oh,
colonels.
Perfect.
Wow, that's
what?
pretty.
Well,
That's
what's
pretty
Manske
impressive.
then? Is he a general too? Geez.
Mansky's a private.
I knew I'd be.
I love it.
I knew I'd be demoted. Demoted on the journal club. Awesome. Okay, well, so let's start here. Let's talk to our guests. Our first guest, I'm going to go in order. I'm going to go in order as you're listed on the paper, not necessarily in order of any importance that I'm aware of. But Matt Gauthier. Matt, can you tell us just quickly about yourself?
Yeah, everybody, I'm Matt Gauthier. I am faculty at University of Illinois Chicago's GPT program and the director of our sports residency, and have had the pleasure of working with Casey and George over the last 10 to 12 years. I'm getting older. So it was really great to kind of combine with two of them on a passion project to make sure we're looking at the athlete holistically.
Cool. Thank you very much. And our second guest, Casey Unverzagt. Unverzagt. I
You
say that right?
nailed it. You
Yeah,
nailed it.
thank you.
Yes. Casey Unverzagt. So I teach full-time for Baylor University down in Waco, Texas. We're a hybrid program. So I actually live in Western Pennsylvania, about an hour north of Pittsburgh. But yeah, I met Matt way back in the day, back in the residency world, and then I've been blessed to be able to work with George here over the last few years as well. Otherwise, my role at Baylor, I help teach much of our, DPT curriculum, but really focus my efforts on residency education. So I'm our director of residency at Baylor.
Awesome. Well, thanks for joining us tonight. And last, but definitely not least, we have the General George J. Davies. George, introduce yourself to people who don't know where you're at now. I guess you could tell everybody where you moved to.
I'm now a faculty member at the University of Texas in Rio Grande Valley. It's the newest university in the University of Texas system. So I'm teaching in the physical therapy program and working as a rehab specialist and rehabbing all the university athletes.
Keep them busy.
Yes, sir.
What's it like working like 20 hours a day for 7 days a week again? Were you doing that before? You weren't, were you? Because you're like covering a lot of stuff now that you weren't when you were.
Well, when you did your residency and fellowship with me, you worked the 20 hours, but remember, I worked 23. So you were sloughing off.
All right. Well, let's get started with this paper, everybody. This is this I've been looking for. We scheduled this one probably. I don't. When was this paper? What month was this released? Do you remember, Barb? It's been a while ago.
January.
Yeah,
January.
early
Yeah,
in the
yeah.
year. Yep, yep.
Yeah, yeah.
Mhm.
So when it first came out, I read it and thought it would just be a fantastic one to go over because it's looking at pitching really from a different lens than I think we normally do, our baseball players from a different lens. The um the title is Evaluation and Treatment of Baseball Pitchers. There's more to assess than the arm, which if you if you work with baseball players, I think you know that, but this really goes in some good detail on what kind of things we should look at. So the purpose of this paper is essentially to highlight the importance of the trunk and the lower extremity in mitigating load to the upper extremity in the overhead athlete. So first of all, gentlemen, congratulations on the paper. Barb, Ash, and Phil, and I guess all of us, congratulations for us to be able to get such a great paper for the journal. It's a really, really good review for those of us who treat baseball players and people with arm injuries. And I guess my first question, and any of you can answer this, is what was the impetus of this? Do you guys treat a lot of shoulder? I know George treats some shoulder problems, but do the other two of you, and have you seen this? Have you found this to be a problem that maybe other people aren't looking as closely at the trunk and the lower extremities for shoulder injuries in overhead athletes?
Yeah, I can start off. I guess it first kind of caught my attention. I was fortunate enough to do some research with some of the docs at Midwest Orthopedics at Rush here in Chicago. And we were looking a lot at the contributions of the lower extremity, specifically the legs, the push off and the plant leg, as far as how it impacts um, uh, force transfer up into the arm. And then that kind of planted the seed. And then anecdotally, I had a patient who I had seen. For just some anterior shoulder pain. I feel like we were doing everything right, just wasn't getting better. Kind of dug in a little bit more and learned that they had some long-standing knee pain on that plant leg, and he just wasn't comfortable planting that leg and really kind of getting that base for that catapult. So kind of realized that I need to take a better look at my practice and make sure I'm assessing kind of up and down the chain. You can do everything right at the shoulder, but really the legs generate the power, core transfers the power, arm just releases the power. So I needed that reminder. I reached out to these two gentlemen. We presented at the Sports Academy conference in 21 or 22, one of those, and then we wanted to kind of take it to a wider audience. So submitted it to the journal.
Awesome, thanks. Barb, do you want to go with the next question?
Sure. So as I read your article and as I looked at some of the history, which I think is really important to understand in this, I know that I've been strongly influenced by Dr. Ben Kibler from University of Kentucky and his colleagues and his early thinking on the description and understanding of the kinetic chain. So that's one of the things that really has influenced my practice over the last umpteen years. So I read his article in 1998, the American Journal of Sports Medicine, The Role of the Scapula, where he describes the kinetic chain. Guys have any interactions with Dr. Kibler, or is this part of your history as well, or something like that? I mean, anybody want to comment on that one?
I guess I'll kick it off. I've had the privilege to speak at some of Dr. Kibler's conferences, as well. I've actually published with Dr. Kibler on a couple of different papers. But interestingly, Barb, you mentioned that you read the article in the 1980s, was it?
Yeah, 1998, I think. Yeah,
98.
later 90s.
What's
Yeah.
interesting, and I went back to take a look at this, and interestingly, the first concept of the kinetic chain
Mhm.
was actually presented in 1933
Whoa.
by Dr. Hans von Baer at the International Orthopedic Congress. Then in 1955, Arthur Stindler actually wrote a book on kinesiology, which further propagated the concept of the kinetic chain. 1979, Atwater in Exercise and Sports Science Reviews further elaborated on it. And then interestingly, Dr. Kibler's first article in 94 actually dealt with the kinetic chain with tennis players. Because he was he was an adamant tennis player himself, and that's where he really initiated a lot of the concepts of the kinetic chain. But we've all learned from him. I mean, we've learned a tremendous amount from him. He's published extensively, and he's been a real, I think, inspiration for many of us to better understand many of these patients who are overhead athletes, and not just tennis or baseball, but also softball, perhaps even javelin. So again, he's been a real inspiration, I think, for everyone.
Thank you very much. I knew I could count on you for some really good information to back all of that up. Thank you.
George, were you at that meeting in 33?
No comment.
Oh gosh, great.
Rob, that was mean.
I know. Hey, did you hear he
Sometimes
demoted me? He
I feel
demoted
like
me to
it.
private. He demoted me to private before we even started. He knew he was going to get a jab back.
You got to remember, I had to put up with Manske a whole year for his residency. So,
and unfortunately, the rest of your life since.
Yeah. Roommates for life.
That's right. That's right. All right. So, authors, any of you here, can you do you mind just not like detail, because I think we'll break into some of these as we get further into this discussion, but can you describe kind of briefly and maybe like an overview of each of the phases, some of the major problems that you would see in each of those phases? And then, like I said, as we go on, we'll probably dive a little bit deeper. So just kind of a 30,000 foot view of some of the problems with each phase of the throwing cycle.
Yeah, I can jump in here. So, I mean, we really kind of traced it back to that original Fleissig model from, I think, 95, because it's just a really good description of the phases. So first you have the windup is really just where the body is readying itself to generate force. So you're going from a position of rest to that position of maximum knee lift. At this point, there's not a ton that can go wrong, except that if they don't have adequate stability in single leg stance, it could disrupt the timing and really have a domino effect, snowball effect moving forward. Then you've got the stride phase, which is going from that point of maximum knee height. They're going to start driving their body towards the target. And it's going to go from that point of maximum knee height to when that front foot hits the ground. So at this point, the biggest deficit we'd see, the biggest issue is they're just not getting adequate drive from that leg pushing off the rubber. So not getting adequate hip abduction, hip extension, because that's really what's starting to generate that force towards home plate. Then we've got arm cocking, which goes from the position of that front foot contact to the position of maximum external rotation of the shoulder. This is really where we're starting to transfer that energy from the lower extremity through the trunk into the arm, building that elastic energy. At this point, I'd say the biggest deficit you probably see is the athlete kind of opening up too early. So we should have pelvic rotation towards home plate first with the shoulders still closed, and then the shoulders should open up towards home plate to kind of get that rubber band elastic energy to transfer that energy up the chain. So then we've got arm acceleration, and that's going to go from the point of maximum external rotation. That ball is going to, or that arm is going to start moving forward. This phase is going to end once that ball leaves the hand. This is really when all that energy that you built up in the legs and the trunk is really released into the arm. This begins at that point of that maximum external rotation, which Fleissig identified as that first critical instant, which is where your internal rotators are maximally eccentrically loaded. It's a very large force, which we really generated from the legs and trunk. And once that ball leaves the hand, that's going to be our second critical instant. That's going to be that point of ball release, which leads into deceleration. So once that ball leaves the hand, we built up all this force with the legs, upper extremity, and arm. Now we got to use that trunk and lower extremity to slow that body down. So when we release the ball, that arm is internally rotating up to 7,200 degrees a second. So not only do we have to have that rotator cuff slow things down, parascapular musculature has to slow things down, your trunk extensors, rotators, and you have to internally rotate over a planted left hip. So you really have to get that entire posterior chain to help slow that body down after ball release. And at this point, I'd say the biggest deficits that I'd see clinically would just be inadequate control or range of motion over that plant leg. So they're having to do all that deceleration with their upper extremity and maybe their trunk, and not able to use that lower extremity. I think that's the overall view.
Yeah, no, that's fantastic. That's a good breakdown of everything. Barb, I think your question, your next question is probably pretty good right here. I think it would be, and then we could go to one of Phil's that I
Okay.
think would fit close after this.
Okay. So your commentary is awesome and it has to do with baseball players, admittedly. I'm just wondering, being the girl in the room, if the same concepts of exam and intervention might likely apply or carry through to the female athlete. Let's just say the overhead throwing athlete, the softball player. And again, I know that pitching in softball players and baseball players is vastly different, but let's just go with an overhead throwing or an overhead athlete. Do you think some of your exam and intervention things that you've got and you've described so adequately in this paper might cross the gender line or the sex line into the female athlete?
I can start off. I mean, I think that, there's so much research in the baseball pitcher, right? Because there's so many injuries in baseball pitchers. So a lot of it is looking at, the push off the mound. And I think that's such a big, consistent thing when it comes to pitching. But really, once you get past that point, a lot of it is very similar. We're still winding up the hips and trunk. We're still having that point of maximum exit rotation and ball release. So I think, you lose a little bit of the applicability when it comes from pushing off the mound, but especially like outfielders or even, on that left side of the infield, third base, shortstop, you're still building up a lot of mechanical energy. So I think any non-pitcher, whether it's baseball, softball, etc., I think there's still quite a bit of crossover that we can look at, maybe just with not as much emphasis on that drive leg. I think the only other thing is, middle infield, arm slots so different. A lot of times they really are getting acceleration from the arm, but the people who are getting a lot of kinetic chain behind it, outfielders, left side of the infield, I think it's applicable to non-pitchers, baseball, softball.
Yeah, interestingly enough, I did a webinar for the AISPT the other night, and it was about female athletes. And we actually looked at what the ratio of research was. It's 8-to-1 male to female on any throwing stuff, which, it is what it is, right? But it's 8-to-1. So that's why I kind of asked this question. I'm like, is there, and I agree that there's a lot of differences, but there could be some things that are takeaways, right? In terms of some of the phases of throwing, for example. Thank you very much. Casey or George, anything to add?
I'll add one nugget. I mean, we spoke to this in the paper too, just about the idea of test, don't guess. So I think Matt is spot on with kind of hypotheses, but all we're putting forth are hypotheses. So what we need to do is test and see, is that consistent with the female athlete or not? But I have a feeling he's spot on.
I appreciate that.
Yeah, I'll jump in. You mentioned the hip and the shoulder. That's a big thing we look at is hip shoulder separation. You didn't really talk about it specifically in those terms in the paper, but you did mention it here because it's more of a kinematic event than a kinetic event. And I just want the readers to understand there's a difference between the kinetic chain and the kinematic chain because a lot of times we get confused that the kinematic sequencing, which is the order of events in the ranges of motion and the speed that those occur, is important. So, example, you guys said the hip has to rotate and open towards the plate while the shoulder remains closed. And the more that you can do that, the purportedly better rotational strength and transfer to the arm you'll get. We looked at that at our quarterbacks actually at Tulane. We published an IJSPT a few months ago, and that was a big part of what we looked at was the hip shoulder separation, finding that is a definite factor. And the kinetic side of things, what I really liked is, and what your paper really spoke to me about was this need to increase or transfer forces from the ground to the hand through the kinetic chain in that sequence, but at the same time mitigate force. So you're doing this balance of creating force, mitigating force. I know you wanted to say 6-7, Barb. I didn't want to do that, but we I know it's these kids that we're with every day. What I really wanted to ask is, as we talk about um the variables that you talked about, hip abduction, on the push off leg, and forward knee flexion at foot plant, and the eccentric load, where do we reconcile the testing, as you said, test don't guess, of open chain testing of strength with these problems that are closed chain and eccentric? We're testing open chain isometric versus closed chain eccentric. How do you respond to that?
I'll take a shot at that. First thing, when you did a great job in your presentation and the article on quarterback throwing, but that's a totally different situation because they don't have the time to do all the windups and do everything because, again, it's a chaotic environment. So I'm not sure we can compare and contrast the quarterback throwing with something like a baseball pitcher. I think they're two different things. But back to your comment, there's, and I just actually presented this in class today, there's 864 articles that actually show the application of isokinetic testing to functional closed kinetic chain performance. So back to your question, yes, there is a correlation. Likewise, we don't just recommend doing all isometric testing. I mean, one of the reasons we put handheld dynamometry and isokinetics in there is I think most of us remember the article by Greenberg in JOSPT in a couple of years ago. And basically, Greenberg actually did a survey of 1,000 sports physical therapists, asked them how they decided to do testing of the quadriceps for return back to sport. 56% of the individuals did manual muscle testing of the quadriceps to make a decision to return people back to sports following a knee injury or surgery based on their manual muscle testing of the quadriceps. As we all know, having taught manual muscle testing for well over 50 years, I think I'm pretty good at it now, but again, I'm not so sure it's pretty accurate. Therefore, if we do isometric testing using handheld dynamometry, rather than the consistent position that seems to be very popular right now at a 90-degree flexion angle, I would recommend maybe 90, 60, 30, because 30 is going to be more functional. Likewise, if you think about it, most of the testing that's done, interestingly, is done in a seated position. But if you look at standing, walking, running, the hip is in a neutral position. That changes the limb tension ratio of the rectus and the hamstrings. So when I do a lot of the testing, I have them supine on the table, then do the testing at 90, 60, 30, because that replicates the hip positions, putting the biarticular muscles in their normal positions of function rather than a flex position. So that's one thing with the isometric testing. I think we need to look at ecological validity, meaning if the patient's walking around in a flexed over position, fine, but most of us are in a more upright position and most of the sports are. So let's replicate that if we're going to do isometric testing. Likewise, when we do isokinetic testing, we're doing the same thing. We're testing at multiple angles, but again, most importantly now, a supine position doing the dynamic testing. And again, you can do it both concentrically and eccentrically, depending on what device you have. So again, as we know, that print leg that Matt just talked about, there's so much eccentric forces on that deceleration that we have to be looking at that. But again, everybody doesn't have isokinetics. So that's why we mentioned doing handheld dynamometry testing of some sort. But at least think about 90, 60, 30, and then also think about where that hip position is. And again, when they're throwing, the hip is not at 90 degrees, like sitting in a chair, but it's at a neutral position. So just a couple of thoughts on some things that I think we need to look at and change relative to doing test, don't guess.
And George, can I just add in, like, objectifying strength is so important. Like you said, you're pretty darn good at manual muscle testing. I think I am too. But the range of what those values mean in objective numbers is highly variable. So the test don't guess relates not only to isometric and isokinetic, but like all the tests that we do as well. And it's like we've got to objectify this stuff.
We have the ability to do it too. So yeah. All right. Well, I want to thank our viewers for sending in some questions. I knew there would get some start popping up here before too long. If we weren't going to get any, I was going to make sure everyone knew that you can put questions in the Q&A. So we have a couple here that I think I'll go to versus some of ours. And the first one is by, it looks like Paul Canavan. Thanks, Paul. What about leg length versus stride length compared to body height versus stride length? Anyone want to try to tackle that one? Also, what about center, I assume center of mass versus plant front leg position with ball accuracy and potential arm injury?
Be careful because he's the primary author, it looks like.
Yeah, I saw. Yeah. He may know a little about this.
Yeah, be careful.
Can you guys see the question?
So it's basically about allometric scaling, right? I mean, about leg length versus stride length and body height versus stride length, right? How do you know for someone's height and length?
Or how do you utilize that?
Mm-hmm.
I don't know those numbers right off the top of my head, but I think Fleissig published some of that information years ago that there should be a percentage. And if I had to recall a number, I think it was about 70% of their height was the stride distance.
I think that's pretty close.
And then again, the foot plant, if it's straight toward the mount, straight toward home plate versus toward third base or first base, that's going to also make a difference on accuracy and the actual throwing. Are they going to be opening up too soon if their foot is planted toward third, or are they going to be closing it if it's toward first? So I think all of those variables, and again, I think Fleissig has really addressed a lot of those questions in the past. And I'm just guessing, but I think that 70% was pretty close to what I remember reading years ago. So
if someone, do any of you know, this is probably something I feel like I should know, but I don't know that I do. If someone doesn't, so if you don't have the normal amount of stride length, or if your stride length is too far, that will affect your pitching velocity. Will that, could that be confused with the hip being weak? Could you confuse maybe someone having hip weakness with a change in their stride pattern?
Yeah, I think, I guess before I forget, George, I think you're right. I think it is 70%, if I remember correctly, was the original, but that's to height. I am not familiar with the research on leg length. That's new. I wrote down, I'm gonna have to look that up later. But I guess, Robbie, your question, and really this might answer several questions. So one thing that we were looking at with our study at Rush, one thing that kind of spurred all of this is, we have this normative data on, what is quote unquote normal and what puts people at risk of injury. But we know from several other sports that people have their own individualized motor programs to develop force in different ways. And so some people might have longer stride and compensate in a different way, or shorter stride and compensate in a different way. So I think, Casey taught me when I was in residency, and I think he's learned from other people on this call, a good sports PT is a good neuro PT. And I think everybody just has their own neural patterns by which they can create this force. So I think painting with a broad brush almost does a disservice to a lot of people. I think we can inform our decisions, but we can't put everybody into the same bucket based on what I've read and learned.
And I think it goes back to what George said. Then and you guys said too, you got to test it. So you don't know. You see some kind of breakdown, or you see a loss of velocity or whatever, and then you test all of those pieces to find out where the issue is. Yeah.
I got to jump in. Sorry, Matt, you just totally made my day. I got all excited. Yeah. Thank you for speaking about neuro PT.
I love it.
But it brings up the notion of this called causal reductionism. Causal reductionism, when we take a really complicated scenario or movement like pitching, we try and boil it down to just like, these are the two most important things. Like, do this or this, and your pitchers are going to succeed. And It's complicated. It's supposed to be complicated. And we never want to boil it down to just gird or stride
Mhm,
length or anything else like we might have once done.
mhm.
So we don't want to overcomplicate it, but I also want to embrace the complexity of it.
That's awesome. Yeah.
Agree. Agree.
Rob, I want to give a quick shout out for somebody I saw that was on the Q&A. I think it's Daniel Malio from Zambia. If we got somebody on from Zambia, kudos to you for coming
There you
on and
go.
listening to the General and Casey and Matt. That is really cool.
What time is it over there, Barbara? Do you know?
I have no clue.
No, no, I don't know either. Oh my gosh. Yeah. All right. So next question, Rob Panarello. We all know Rob really well. George, what is the standards you're looking at during the supine quad testing?
Similarly to what we looked at before, once again, if I'm using handheld dynamometry, as I said, I would do the 30, 60, 90 positions. And then if I'm doing isokinetic testing, I would do, I still do velocity spectrum testing. I do 60 degrees per second, 180, 300. And the reason I do those numbers, a lot of people do 60, 180, 240, but between 180 to 240, there's only a 60 degree per second difference. You're not going to see a differential in the forces. But if you go 60 to 180, there's 120 degrees difference. If you go 180 to 300, there's 120 degrees difference. Therefore, it's going to show a difference in the velocity spectrum forces. So we look at number one, we look at obviously limb symmetry. But again, people have an injury, the involved arm drops down, but from the non-training, the uninvolved side usually decreases as well. So if we only look at limb symmetry, we normalize, but we're really below the original functional level. So in addition to looking at limb symmetry, we also look at allometric scaling, meaning to their body weight or size or whatever, height potentially. For isokinetic testing, we use body size, weight. For some of our functional testing, like med ball throws and things like that, then we normalize allometrically to their height. Furthermore, we look at unilateral ratios in the different positions. And again, everybody says, well, you know, at the slows, everybody says the hamstring should be 2/3 of the quads. That's only accurate at the slowest speed of 60 degrees per second when it's in the traditional position. The angle specific torques will change based on the speeds and based on the positions. So there's so many variables there that we can look at, but that's what I do. But with those who don't have isokinetics, if you do handheld dynamometry, at least don't just test in the 90-degree position in a seated position. It's not a functional position for the knee or for the hip. So at least think about supine and putting the knee in different angles that are more functionally replicating different positions of walking, standing, running.
I just have to jump
That
in real
answers it
quick.
or not, but
George, go George. I would say that if anybody on this call has not read the Isokinetic Compendium that was authored by George Davies, you need to read it. It is something that is seminal in our profession. And for those of you who think that you don't or get the idea about isokinetic testing or why you do it and how you do it, read the Isokinetic Compendium. I have one on my shelf still, George. And it's like it is the thing that helps you really understand what you're doing. So just a quick plug in for the general.
Thanks, Barbara. That's sweet. It's very nice. Casey, can you guys talk in the paper about, you briefly mentioned the whole Dizzy Dean story from years ago. Do you have some other potential examples that you think you would see clinically that are similar to that, kind of in that same vein, that people normally see with baseball players that are worth mentioning? Some common ones.
I mean, I think we could see it as simple as an ankle sprain or a loss of ankle mobility. It doesn't have to be a great toe, but at least in the college environment, we see a lot of your Friday night escapades. No, I just rolled my ankle on a Friday night, and all of a sudden, my pitching is impacted, that next week. It's like, well, there's a correlation there. So, may not be the Dizzy Dean, but similar experience.
Yeah, yeah. No, that's great. That's perfect.
I do need to elaborate on the Dizzy Dean. Many
Please.
people aren't familiar with his story, but he was a real character that pitched for the St. Louis Cardinals. And basically in the All-Star game, He basically, Errol Ivory actually hit a line drive back and it fractured his big toe. So consequently, he was such a character and very cocky about everything. He continued to play because the St. Louis Cards actually qualified for the World Series. So he actually ended up playing in the World Series, but because of the big toe problem, he compensated with his throwing mechanics, and therefore he only lasted a couple more years. But at any rate, he did end up playing in 2 World Series, but never regained the form after that fracture. So in the article, we mentioned the concept. So you have to look at the patient from the toes to the nose. So look at the entire kinetic chain, because as Casey also just pointed out, you can sprain an ankle, you can have a foot problem, and that in turn can actually affect the entire kinematic chain and then ultimately resulting in the throwing motion. So that's just an interesting story that really, I think, sensationalizes the concept.
At least Dizzy got hurt playing baseball. It wasn't the Friday night escapades or Saturday night escapades that we all hear about. Those are rampant down in Louisiana, right, Phil? The escapades. You guys?
I don't know that we can spell that word. I can say shrimp Creole, crawfish etouffee. That's about it.
You got us there for sure. Did you? When you're making some for Thanksgiving?
No, I just made 20 gallons of gumbo, some andouille and chicken gumbo yesterday to sell for
Nice.
the students.
Awesome.
Yeah.
Wish I was closer.
Anytime.
You could do it on some dry ice, right? You could send some on dry ice if I
Anytime.
Venmo or something like that.
Well, George is a lot closer to me now. He's going to have to make a road trip. He's a lot closer to us.
He's way closer.
Yeah.
Got to check
All right,
out
guys.
the brew shack, baby.
Come
Very
check
cool.
out the brew shack.
All right, you guys described. I really like that you guys described doing when you talked about your exercise progression. You talked about doing clamshell exercises, and I just because I watch social media and I see like so many people just hammer the crap out of how horrible clamshell exercises are. I'm glad that you guys included them. Clamshell is like sometimes treated like the unwanted stepchild and gets a bad rap. So I really want to know your thoughts on the clamshell, why you decided to include it, what you think is great about it, and why you like it.
I love how you frame that. So yeah, I think the clamshell discourse on social media is pretty wild. I mean,
It's kind of comical. It's wild. It's comical. It's crazy.
it is. I mean, if you say I did a clamshell with a patient, it's almost like you just insulted their dog. Like, how did you do
Yes.
that? It's just terrible. So I think, I mean, at the end of the day, I think the clamshells, it's just a tool. It's not the holy grail of hip exercises, but neither is it useless. And so I think what we've landed on is, okay, sideline hip abduction, external rotation, they do activate the hip abductors and the rotators. And in pitchers, we know that, these muscles tend to be deficient. We know that if you have a weaker drive leg and, weaker hip abduction strength, they tend to be weaker than your position players. That correlates with upper extremity injuries. So the point we want to make, though, is that a clamshell is not going to magically transfer into throwing. And so it's a starting point. By no means is it an end point. I think about someone after an ACL reconstruction. We want them to jump. We want them to cut. But 3 weeks out of their ACL reconstruction, I'm doing maybe a quad set or a little mini squat. I'm not jumping. I'm not cutting. It's a starting point. So I guess I would truly liken the clamshell to that quad set early in rehab.
Yeah.
It's like we need to teach them what external rotation feels like, what it looks like, how do they control the pelvis and the hip, then eventually transfer to closed chain. So yes, clamshell's not a villain, just the misuse of the clamshell is probably the
I agree,
villain.
Casey. And Casey, I got a news flash for you. It's not just baseball players that have weak hip abductors and external rotators. It's like almost anyone with a lower extremity injury seems to have weakness of those.
It's like all my runners.
Yeah.
Oh,
Yeah.
Yep.
I'll just chime in as the hip specialist on the panel that it drives me insane that the clamshell has been just
vilified,
blackballed from all exercises. So
I was ready for you to tear me apart.
I will advocate for a proper clamshell, and there's lots of ways to make sure that the clamshell is done correctly. So,
Yeah.
Or Casey, like your framing of it too, like it's not the end. If you end there, you're
Oh, yeah.
stupid. If you start there, then maybe that's a means to an end, right? It's like a spot
Absolutely.
to start with.
Yeah, by no means the end to all, but it is in its own right. I still feel like it's a very valuable exercise. The other thing that I really liked about this page, I guess I really like these because these are kind of how I treat and how I think of things. But you also started discussing doing your the hip, when you find someone with some significant hip weakness that is translating to these problems, maybe actually not even starting them in weight bearing, but starting them like clamshells in sideline or supine, or doing some of the hip exercise where you're not significantly loading it initially and actually doing it in non-weight bearing. So again, give me some justification for that.
I want to hear Matt was going to try to say something, so I want to hear what
jump in, Matt.
Sorry, I think this could apply to maybe what Casey's going to say too here. I don't think it matters, whether you have a quote unquote functional hip abductor external rotator exercise as well. If you underload it, it doesn't matter what you do. And I think you can pick a very basic exercise and make sure it's loaded appropriately, and it's going to move the needle for the athlete. So I think to say an exercise in and of itself is bad or wrong is throwing the baby out with the bathwater. If we load it enough to make a physiological change, that's what really matters. So you have to talk to the patient and say, is this hard enough? How many more reps could you have done? And then that informs, is this hard enough? Is this appropriate? But loading matters so much.
We'll also go back to your comment about sports PTs and neuro PTs. Like, a lot of people aren't utilizing their actual like deep rotators and their whole rotational complex, if you will, appropriately. So they'll say, oh, if someone tells me they repped out, 100 resisted clams and it was no problem, I'm like, you didn't do it right. Right. So we got to go back to like, are you actually doing the pattern properly, and kind of more the neurological side of things, even more like even before the loading to some degree.
Great. Let's go back to a couple of our questions here. We have another good friend of all of ours, Andre Labby. What is the significance of front leg extension speed after foot plant? Is that one anyone wants to try to?
How do you measure extension speed after foot plant?
I
guess
what's the significance of it?
Because you're actually, are we breaking the quad, breaking knee flexion?
Are you accelerating the hip extensors?
Oh well,
I think you're breaking the knee flexion, yeah.
Because that's the thing, is eccentric quad.
At foot plant, anyway.
Yeah. All right.
That's what you get for taking an Andre question.
That's right.
Well,
so this next one maybe is a little better. This next one from Andre is a little better. Maybe this is a two-parter. Also, what the hell is he even saying?
Shoulder pitchers? He's great.
Shoulder pitchers, actually.
Also, shoulder pictures, actually. I think he's been drinking too much, apparently. I think he makes sense of this question. No. Also, shoulder pitchers actually be in good fielding position after ball release. I'm done reading Andre's question. He's just making statements.
Should pitchers be in good fielding position after ball release? We see that our better pitchers end in a poor fielding position.
What's scary is that you understood his damn question, Ashley. You actually understood it. That's frightening.
I've spent a lot of time with Andre.
Should pitchers be okay? So that is the question. Should pitchers actually be in a good fielding position after ball release? I think that's pretty obvious, isn't it, guys? Is that a yes?
Yeah.
I'd prefer them to be able to see when that ball's coming back. Yeah.
Just in case.
Okay.
He just got a brand new outdoor kitchen, so I think he's enjoying it a little bit too much tonight.
He said, should pitchers be.
Another one from Paul. I don't think this is a question. This is just an important statement. An army without leaders is like a foot without a big toe. That's Bill Murray from the movie Stripes.
That's awesome.
You're talking about Dizzy Dean.
Yeah.
How about do you observe a relationship between visual field and environmental recognition in pitchers? This seems like an Andre question to me.
Yeah.
I think
I mean-
that's where some of the neurocognitive
Yeah.
testing and the neurocognitive training is coming into play now. For years, we really weren't as in tune with that. In the knee, it certainly has been. But when you look at the literature right now, there's only 7 articles on neurocognitive in the upper extremity shoulder area. And frankly, half of those deal more with neurological conditions. So there's only 3 articles in the literature right now that deal with neurocognitive testing and or rehabilitation with shoulder related problems. So again, I think it comes back to the dual tasking or the multitasking responses. And again, as we know, with most sporting events, everything is occurring as reactive responses many times and in milliseconds. And that's what we need to start thinking about from ecological validity of testing and training and rehabilitation. Because when that pitcher is throwing that 100-mile fastball and then that ball's coming back at 120 miles an hour, they need to be able to react quickly. So back to the question, I think it means, yes, you better be in a position to react after the pitcher throws that pitch. And I think back to Matt's original comment of going through the phases, if somebody, when their follow through rotates too much, they're not going to be in a position for, say, a line drive coming back at them. So I think that's an important concept. Just one, they have control of the follow through. And then secondly, I think we need to start doing more of the neurocognitive training.
Mhm.
Hopefully we get that up to 4 or 5 articles on neurocognitive testing for the upper extremity by year's end, George.
Yeah, for
We're
sure.
holding you to that, Matt.
We're waiting.
Trying.
Yeah.
We have a few articles in review, and we've got some multi-center study research going on in those areas. So we're hoping to really start, I guess, exploring that area and coming up with some better solutions.
Yeah. All right, Barbara. Barbara, you had another question?
I get to go?
Yeah.
All right. So I was super excited that in your article you mentioned segmental rolling. So it's one of those things that's been high on my list of things that's really important. I think it really relates to this whole neurological sequencing of what goes on. So tell me how you use it for exam and what are some key examples of when the trunk and extremities are just not in sync, like how that affects what you think about a picture, for example.
So I'm going to give you the medium length answer and also call it confession time, Barb, because like that question has a stamp on my memory. The short version, I have 4 kids, 3 we adopted from Ethiopia. We've gone back and forth to Ethiopia a lot. And when we brought 2 kids home, my wife and brother-in-law actually brought 2 of them home. And as I was waiting for them at the Washington Dulles airport, I was reading your article on rolling. And I thought it was the dumbest article I've read in so long. I'm reading this thinking, there's no way I'm ever going to do this with a patient. This is nuts. But I had such a high regard for you. I said, well, if Barb is saying there's something to this, I at least need to try it. And then my kids landed and okay, eventually I'm like, I need to try this stuff in the clinic. And that was, shoot, 10, 15 years ago. And it is one of the most foundational both tests and treatments that I will use. So I was wrong. You were right. Thank you, Barb. But I will say it, I love it because it's probably the most low tech kind of have or high value test out there. I see pitching really as a timing and a sequencing sort of activity. So we have to understand again how things are timed, how they're sequenced, and rolling gives us a picture into how they're doing that. So we'll typically look at soft rolling and hard rolling. If you look at soft rolling, we'll look to see, do they initiate movement through the trunk or do they cheat as they push through their arms or their legs? We'll look to see, kind of disassociate their upper trunk from their lower trunk. Sometimes we'll see that one movement, one direction is super robotic or just kind of awkward, whereas the other movement is much more fluid. We'll get down to looking at, breathing and rib motion and pelvic control. And it's no surprise that if it looks really broken when they're rolling, their pitching looks pretty broken too. They just tend to be very, very inefficient. So that even remotely addresses your question. I love it.
It does. It does. Casey, if you ever want to write something more on rolling, I'm in.
All right. Yes.
To throw out there too, that was drilled into me is really the first thing we have to do is make sure they have mobility to do that too, right? Like the control is important, but they have to have mobility to actually rotate. So you can't penalize somebody for not segmentally rolling if they don't have mobility to do it.
I'll call out all my SFMA friends. Don't bring a mobility problem to a stability party.
No,
I'll say the one thing, the hard place I didn't know where to go once I feel like they mastered the rolling. So it might take 5 minutes or 5 sessions. It takes a while sometimes. But then where do we go from there? And so it's one of the things within the paper we talked about, just kind of a progression from, cardinal plane motions to isometrics to more transverse plane things to more dynamic. There's lots of goofy PT exercise names we use in the paper. Like, forget the names, but if we want to emphasize, just have a good logical progression with that kind of transverse plane control. That's going to be vital for those throwing athletes.
I just want to bring it back full circle because all this is good. We went from our regular, open chain testing to neurocognitive to neurodevelopmental. Let's come back. One of my questions was when you guys were talking about the MMT, you're looking at 90% limb symmetry index. My issue is kind of like, well, pitchers generally have asymmetries to begin with, which is very functional. So where did the 90% come from? Is that actually a good number to go with, or are we just kind of, picking that? What's y'all's opinion on that?
As we know, with the pitcher, there's an asymmetry in the range of motion from the GERD erg, and Manske et al. Published on that many years ago. So you get your increased external rotation with your decreased internal rotation. But moving on to the strength factor, what's interesting when you look in the reference lists of the articles for this publication, there's several articles that are published in there, a couple of them by Riemann et al. And we looked at the limb symmetry index concepts. And what's interesting is in people that are active, not just throwers per se, but people that are active, there's really not that significant of a difference in limb symmetry. Furthermore, when article in IJSPT in 2023 with Wilk, Thomas, Mangine, and Davies, we actually published information on all the testing. In there, we included a lot of tests called the single arm seated shot put test, prone ball drop test at 90-90, and abduction and functional throwing performance tests. Interestingly, they were also with overhead throwing athletes. And interestingly, the involved overhead throwing dominant arm is within 10% of the non-dominant arm. Because we think it's going to be much stronger, but what's this whole article about? It's not about the shoulder, but it's about the entire kinetic chain. And therefore, it's not just somebody being stronger with the arm itself, but it's because they're throwing with that dominant arm. Years ago in the 70s, we actually did some testing at the NFL Combine. And when the kicker, using isokinetics, when the kickers came in, I said, oh man, their kicking leg is going to be off the charts. Interestingly, the kicking leg is weaker on every kicker. And the reason for that, when you think about it, the non-kicking leg is their stance stabilization leg, which is stronger. And frankly, the kicking leg just swings through the breeze, just like in throwing. So that 10%, even though, as I said, that article in IJSPT 2023, we list all that information. And I think that's pretty valid because that's based on a lot of professional and university level type of pitchers. So that's where that evolved from.
Perfect, George. Thank you so much. That was awesome.
Really good.
Great. I think this question really fits in good. That's kind of a lead into it. I think, George, from Zach. Great article. How do you recommend we prioritize all of the tests and measures into a clinical examination efficiently on a first-time visit with a baseball player? So you talked about testing a lot of things. What kind of order and how do you prioritize them? Let's say you have someone that is being sent in. It really just a one-time visit for evaluation of, shoulder problems, baseball player. How do you prioritize, and kind of what order do you do your examination?
With a one-time visit, I think it's going to be extremely difficult, frankly. But if you, one more time, go back to that article in IJSPT 2023, we have a list in table 1 of different tests that can be done. The thing that we haven't talked about, and I just alluded to in response to Phil's question, is we need to also, besides doing all the range of motion, doing all the different mobility testing, doing the handheld dynamometry and/or isokinetics, the final kind of, I think, transition is doing some types of functional testing. And that functional testing, I think, is the segue from the clinic back to the actual field environment. But again, in a one-time session, I'm not sure I could do a lot of that. It would take at least a couple of sessions, prioritize the fundamental things the first time, and then see if there's deficits there. Then predicated on what you find there, then I would segue into the more dynamic type of testing. That's at least how I'm doing it right now. Right now, I'm seeing baseball, quite a few baseball players, but interestingly, every baseball player I'm seeing right now, everyone is post-surgical. Several shoulders with slap lesions, even a Bankart from a person who dove for a ball, UCLs. And again, that's how I would do it. I would do the basic stuff first. And then when they get to the timing factor, got to respect time and soft tissue healing, but then also your criterion-based information to progress the patient and do the testing is how I would try to do that.
Rob, if I can just offer one complimentary perspective, George, I agree with everything you're saying, and I'm trying to wrestle with, if I only have one visit, what am I going to do? I think we want to keep this in context too, that we know how much volume, just throwing volume is going to impact risk of injury. I'm going to spend a whole lot of time talking about that. Forget the biomechanics in a way. Let's talk how much you're actually throwing. But that aside, at least with a lot of the athletes that I will end up seeing, they actually have decent arm care programs. Not stellar, sure, I'd like to tweak them, but decent arm care programs. Where am I going to spend a lot of my time? The lower quarter, because that's what is not being looked at by their strength conditioning coaches, by the athletic trainers, or by their pitching staff. So just a different way to look at it.
Yeah, nice.
Thing in here. I'm sorry, I know there are a lot of students and early clinicians on here, so I just wanted to throw one more thing out there. I had I think a simple answer before you said one visit. And I think what it comes down to is, I don't know if anybody else watches Parks and Rec, is a big Ron Swanson fan, but you can half-ass one thing or you can whole-ass something. And I think if you are going to try and spread your attention out and try and be all things to all people in an evaluation, you're going to do them a disservice. Mm-hmm. So I think you need to focus on either the upper extremity and the history in that one exam, and you do a really good job on the lower extremity and subsequent exam, but you just can't do it all in one session and do a good job unless you're seeing somebody for 2 hours.
A lot to unpackage. So one more quick question that I think is great here to kind of close on, from Jacob. Where do you draw the line between physical therapy and being a pitching coach? Because I understand 100% what he's talking about, because sometimes a physician will send them in and want you to do like a throwing evaluation of the person who's having pain and everything. I feel it's sometimes hard to input changes when pitching coaches are involved. At least if you're treating someone in an orthopedic setting. So you're treating them in the orthopedic setting, they're having their shoulder problems, maybe they're getting better, maybe they don't have bad shoulder problems, but you're evaluating all of their lower extremity stuff. You're looking at maybe at their pitching motion. Where do you draw the line between trying to change things, but not step on the toes of maybe a pitching coach in a college program or something like that, or professional, I guess, realistically?
I think you try to work collaboratively. What we're doing, again, if I'm seeing somebody in the physical therapy clinic, then I'm also working with the athletic trainers when they're going back to some of their information. And then we're also working with the strength and conditioning performance people. And then they have their specialty coaches on the team. So a lot of times we'll even get together in a kind of a Zoom call, talk about the individual and what needs to be done, so we're all on the same page. So I think that right now, because I'm in a university environment, I can do that. And all the players are involved in that environment. So I think that's the best thing. Instead of exclusively doing it, I think trying to work collaboratively with one another is one way of trying to do it, and educating everybody, including the patient.
That
That-
sounds crazy. Are you recommending we actually communicate with somebody?
Occasionally that helps.
I'm embarrassed to say, as I look back at like my early career, I used to see, a pitching coach like that almost as I'm saying adversary, but an obstacle. I need to somehow get around them. So my 1 or 2 hours with that athlete, I think, I've got so much wisdom that pitching coach doesn't have, where that pitching coach is spending countless hours with them and has such a great understanding. So that's why we talk about a sports medicine team. Like I'm one
Exactly.
piece of the team, but there's so many different people that we need to bring in.
Awesome answers, guys. Awesome answers. Well, guys, I cannot thank you enough for joining
Amen,
us
brother.
tonight. This has been awesome. It's exactly what I was hoping it would be. And like I said, I've been looking forward to this since I saw this pay. I don't think I even asked you in January. I think I asked you a couple months later just because we had some people already lined up. But in my mind in January, when I saw this paper, it was anticipation of hopefully you guys wanting to join us and discuss it. So thank you for very much. You made my evening, and my guess is a bunch of other people's evening. Barbara, do you want to introduce the
I'm gonna take it because,
point? Oh, okay.
in all honesty, I was delayed in getting Barb any information, so I'm gonna bring
Oh,
Bo
okay.
on,
That's
and
good,
I
all
think
right.
it's Cavaness. Is that correct, Bo? Bo is a recent ATI sports resident graduate from Birmingham and is currently actively working in Birmingham at ATI. He actually is a former collegiate baseball pitcher, and did one of his last PT school rotations with Baltimore Orioles. So certainly in a great position to jump into this topic to do tonight's ATI IJSPT case in point. So Bo, I'll let you go ahead and unmute and go ahead and let me make sure I'll make sure you can share your screen here. If you have slides, you don't have to have slides, but jump in and go ahead with your case.
Right. Let me see if I can get this pulled up. All right. Are y'all able to see that?
We got you. Yep.
Okay.
If you can, it's in the like preview. There you go. Perfect.
All right. Excellent. So a lot of the things I'm going to talk about tonight are similar to what this group has so well put together and explained, but kind of putting some more visual images on the things that they brought to light that were really important, because I'm a big visual learner and seeing it as opposed to just talking about it. And so I'm going to talk a little bit about that and then also give an example of a few cases that I've had as well, that, as Dr. Davies had talked about, are post-op surgical, but also had some other secondary impairments that we addressed or needed to be addressed in addressing that kinetic chain. So a couple of key takeaways that they talked about: trunk rotation playing a key role in the elbow valgus torque and ball speed. So obviously a big need for that power development that they talked about, as well as being able to have the strength to develop on the drive leg on the back, the hip abductor strength, which you can see very well positioned there on Aroldis Chapman, really having to sit into that back pocket is what a lot of pitching coaches will talk about before you drive down the mound. Another one that was highlighted very well is that eccentric strength. So that front knee having to get forced into a lot of hyperextension to then kind of vault over that front side knee, transitioning that power up through and over that front knee. And then hip internal rotation around that 30 to 35 degrees, again, sitting into that back hip, and then it almost kind of slams into closed chain internal rotation. So obviously could see if we don't have that mobility, it's got to come from somewhere else. So typically it's going to come from the low back or transition up into the torque. Something's going to be having to play, having to have more mobility to try and play catch up for the lack of that rear side internal rotation. And then the last one here, put very well by Spencer Strider, showing the importance of being able to drive off of that back rubber. So again, having that closed kinetic chain dorsiflexion, but also that controlled ankle mobility to be able to set as much weight through that backside and then drive through. So I got four patients here that I'm going to talk just briefly about. First one was a 17-year-old kid, internal brace, secondary ulnar nerve transposition, was done by a physician here in Birmingham. We also were able to have the physician take a look at that backside hip. He'd been having a lot of pain for about 2 years, and come to find out he'd been dealing with a labral tear as well. So we were able to early on get that repaired on top of him having the internal brace. And so I think that set him up for success moving forward. But again, as you can imagine, there's going to be a lot of things that we have to address, especially as we get further out in the kinetic chain itself. Second one was kind of more of like a case trial, but UCL reconstruction performed by a physician in Los Angeles. The third case was a shortstop, had the internal brace done as well, physician here in Birmingham, and also had a precursor of a partial tear of the UCL, and we attempted for about 2 months to rehab it conservatively and weren't making the success and strides that we wanted. And so he ended up indeed having that internal brace done. And then an 18-year-old, which I'm sure everyone here commonly sees. So first started dealing with arm pain at 16, was playing on 3 teams year round, and then showed up to the clinic and was diagnosed with Little League elbow and GERD. So I also included a picture at the top of Shohei Ohtani, obviously probably the greatest baseball player to ever live, but up for debate, and just won his 4th MVP. But in 2018, underwent full Tommy John reconstruction, and then most recently in 23 underwent the hybrid approach, where it's a combination of both Tommy John as well as the internal brace. So obviously this is becoming an extremely prevalent thing, and just goes to show that not every individual is inhuman. Everyone's susceptible to these types of injuries. So talking about this is kind of my criteria. I know a question was asked about, what specific things do you look for on your first day and your first assessment? And so a lot of these things I've added throughout my time of treating baseball players from day one. A lot of things that I know that I had deficiencies in whenever I was playing. And so I would encourage everyone that treats baseball athletes to just sit down and write out your list and say, okay, from head to toe, what do I think is most relevant, from cervical spine all the way down to the foot, and strength as well as range of motion. And I think the article that was presented tonight as a lot of very valuable and a lot of vital things that we should be looking at and trying to address and getting ahead of those deficiencies first. So the outcomes with all 4 of these individuals, first person, again, we talked about, had the hip labral repair as well. Because we had more time for the season when it happened in the summer when he actually had the internal brace put in, and then obviously had to gradually work on improving our outcomes with the labrum being repaired, and then addressing any deficiency we were going to have moving forward, especially when he started getting a lot more into plyos for the upper extremity. We had to make sure that that back leg was able to drive the way that we wanted to produce the power up through the rest of the kinetic chain. And so it was just unique in that aspect of seeing how one thing had to play off of another, or else we would face a setback for both things at once. He was able to, we had a little bit longer time, so 2 additional months than what we typically have these guys return to, but that 14-month period, and that was again unique because of the injury that he had during the summer. Second case, 19-year-old kid with the reconstruction. Again, this was more of a control because he didn't have any other secondary impairments that required surgical intervention. But from day one, we were addressing all of the things that I had mentioned in that assessment that I'm trying to do with every baseball player. But returned at 12 months and did not fully return his prior level of play, which was AA. Starting pitcher, until 16 months, which tracks with a lot of the current research right now with these return to UCL reconstructions. That 12 months is about that sweet spot that we should expect them back to fully playing, but then not till about 15 to 16 months that they're returning back to what their exact prior level was at that point. Third kid, 21-year-old internal brace, was a shortstop. So obviously he was able to return to playing at 5 months, a lot sooner compared to obviously your starting pitcher. But again, not as much stress, even though, we're making high level throws from the shortstop position. But with the return to throw that we discussed with the doctor at the time, he was able to start return throwing at about 3.5 months, and then put together a plan that was specific to his needs that allowed us to be able to make around 120 throws from the shortstop position with slow rollers, backhands in the hole. So we felt that he had applied enough torque to his arm and his elbow, similar to what he would needed replicated in the game, to where he could return back to playing at that quick time. And then last kid that we had, he was with the Little League elbow and then the GERD. Shut down for 8 months, obviously for the Little League elbow, allowing time to heal, and then participated in 5 months of physical therapy. He did return to pitching fully at that 8-month part, or the 8-month time frame, exactly related back to when he was originally diagnosed with it, which was great because when he first came in, he had been diagnosed. So originally diagnosed at 16, Little League shoulder or Little League elbow, rested, came back and said he was diagnosed with Little League shoulder. After that, rested, came back, and then we realized that he was having back pain. He had mentioned that to us, and all of this was directly correlated to his lack of hip internal rotation on that back drive side and lack of thoracic rotation and extension, to where his arm, his elbow, and his shoulder were having to play catch up again because he wasn't getting that movement when he was going into layback. And we were able to address all of those impairments on top of, obviously he was at the time 16 and, growing and getting stronger, but able to address a lot of those impairments that set him up for success, to where when he came to us for that most recent diagnosis and address those impairments, he was able to resume exactly back at that 8-month mark. And some clinical pearls. I know I've been treating for about 2 years and just graduated from the residency program. And so I've grown very fond of treating the baseball athlete from the time that I played to the time that I was able to go train at Driveline and kind of dip my toes a little bit in the biomechanical world, to now being able to treat a lot of, minor league and some major league players. So these are just a couple of clinical pearls that it would have been nice for me to have known early on, that I've kind of learned throughout my time now. But understanding that, yes, we've talked about numbers and they're extremely important, but it's not the entire picture. You have to look at the athlete for the athlete. You'll have guys that will be, the fear of throwing for the first time when they return, and you say, okay, maybe we need to try a few different, neurocognitive things to set the stage for throwing at that point. I've also learned that, a lot of clinics for here locally that I've seen, a lot of baseball players, when they come in and they have shoulder elbow problems, let's give them, the thrower's 10 and the advanced thrower's 10, and they're ready to go. Well, throwing a baseball is by far the most violent and fast motion in all of sports. And so if we're not, in my opinion, doing a job of loading these guys like they've talked about, at ball release, eccentrically, getting them into full shoulder distraction positions when they're at ball release and challenging them in these planes, then we're doing them a disservice and not setting them up for success moving forward. Like we've talked about, addressing the kinetic chain impairments, but trying to work best on them from a maintenance standpoint throughout the season, because we know research has shown they're going to lose range of motion gradually throughout the season, even from the beginning of the game to the end of the game, but trying to maintain what they have and gain, if we can, throughout the season, will help us to try and decrease injury rates to the absolute max that we can. And then, like Dr. Davies talked about, the importance of each role in the rehab process. I felt like I knew a lot about pitching mechanics, and then I spent 3 months with a pitching coach at a very high level and was like, wow, I know like 0.001% of what they spend with these guys. And the same goes for strength and conditioning. I feel like I know a good amount. I studied to take my CS, but I'm very, very foundational knowledge compared to the time that the respective groups put in for them. So the importance of just that intercollaborative communication and not being a stranger, to work on the same team to get these rehabs and these baseball players to the absolute best level that they can. And two other things, just knowing basically that not every person is going to be the exact same quantitative number. So it might say at 15 weeks they're ready for two-hand plyos. Well, you have to use your best judgment and what they're communicating to you to determine if they're ready versus just what a number says on, protocol. These protocols are great, but you have to make it each athlete specific. And that also goes with their structure, throwing and pitching programs, because they're gonna have a setback. If you treat enough of the players, you'll understand that setbacks are inevitable. But how can you adapt it and give them the confidence to know that this is just a little bit of a hurdle, but we're going to come back from it better than what we were before. So that is all that I have.
Thanks,
Thank you,
Bo.
Bo. That was
That was
awesome.
awesome. Really,
Yeah.
we're gonna be
Nice
stereo,
job.
Ash.
Yeah. Nice
Yeah.
job.
That's
That
great.
was a great way to wrap that up and kind of recap all the really key points. So, and we didn't coordinate any of that. So very, very good. Any last questions from the panel for Bo or anything? I know we're at time, but okay. Well,
Good.
thank you, Bo, for joining us. That was great work, and hopefully some encouragement to those young professionals that are on this. And thank you to all the over almost 300 people that still hung around to stick around for the case in point tonight. So we appreciate you guys. We got one more for 2025 on the docket for December. So hopefully we'll see you guys again next month, and then we'll get that 2026 schedule up and running. So. All right. Thanks, everyone. Have a great night.
Good night, everybody.
Thanks, guys.
Thanks, everyone.